Thank you. So at the outset, I'd like to thank also my wife, who's also a vitreoretina specialist, Kanika, for helping me give the narration for the video. And I'll just go ahead with this case. It's a lady who came to us, and I'll start with the video, and probably we'll have the discussion at the end.
This is a story of an incredible journey of hope that took us from darkness to light. Our patient was a 50-year-old lady brought to our clinic by her neighbors. She had no vision in the left eye since childhood and had now developed vision loss in right eye over the past 3 months. She had no caregivers and was now totally dependent on her neighbors for activities of daily living. She had never been systemically evaluated. Given her monoocular status, it was imperative to do something, and do something fast. Standard 3-port pars plana vitrectomy was initiated. We can appreciate scleral thinning nasally. We knew right away we would need a phacophragmatome to tackle the rock-hard nucleus. But even a phacophragmatome was no match to the tenacity of the nucleus. Finally, we could overcome the devil. Now lay ahead the Herculean task of tackling the retina, which looked nothing more than a crumpled piece of paper. After switching to bimanual dissection using mini light source, we made further headway by injecting PFCL and started to unravel the delicate retina tethered precariously to the optic disc. The membranes were firmly adherent to the retinal surface. At one point, attempts to remove a tenacious membrane in the superior retina led to retinal rotation and a catastrophic risk of a large retinal tear or even disinsertion from the optic disc. It was like walking a tightrope. But we managed to hang on. So, it was important to go very gentle and preserve maximum retinal integrity. Finally, the seemingly impossible retina unfolded completely. At last, the eye comes back to life. 360-degree endolaser was performed under PFCL. Lastly, PFCL oil exchange was done. Seeing the patient walk independently at 3 months made all the nerve-wracking and heart-wrenching moments that we just witnessed absolutely worth it. 。     。  . 。  . 。 . 。 . 。 . 。 . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . 。 . . . 。 . . . .
This is a story of an incredible journey of hope that took us from darkness to light. Our patient The one and only Eagle Double G.
Okay, so I
Fantastic.
think that I'll just stop, and I'd love to hear the comments from the audience.
Fantastic. Great job.
Great
Uh,
case. You see, honestly, I would know. I have operated 360 GRTs, but I
I'm
think
sorry,
this
I'm
was,
not able to hear.
yeah. So I will put in the chat box that this was one of the toughest case. Honestly, I would, if the other eye was good, I would not have operated this case.
I think Darius has shown a similar video a couple of years back.
yeah, but any thoughts on because one of the challenge which we all face in this type of cases is the rotation.
Yeah.
Means obviously you don't worry too much that okay, at least the patient should get vision. But how do you
Yeah.
actually prevent rotation if it is already 360-degree torn apart? Any thoughts or comments on that, Dr. Giridhar?
I think, I don't know. I mean, basically, I think our aim is only to fix the retina, right?
Mm-hmm. Yeah.
See,
I think good job is because the first thing is he always, because now of course you have a good instrument, but the bimanual surgery, what is decided to start with, because when the retina is so mobile and having a subretinal membrane also, I think excellent thing is just he started with the bimanual. Generally quite sometimes these eyes, there's hardly any vitreous. Only thing is just membrane. And, and you ensure that you have mobilized the retina well. And what you need is like a very slowly you start injecting PFCL. Periodically look at where your fovea is, macula is rotating. And probably you have to bring back, and probably when you go beyond the macular area and arcade is flattened, you look at it again, macular position. And suppose you feel is rotated away from, from the desired location, either you are back flush or gently cutter suction, you hold one edge of the GRT, tug little bit, try to bring it back. Because the early stage, if you do that, it will rotate back it because it is sort of a stretched and contracted retina. Once you start feeling, as keep on adding and keep on simultaneously drag the edge back to ensure that foveal is in place, and then it holds on.
Absolutely, very nice.
But I
And
think this being one-eyed, even if a bit of rotation is present, I think it should not matter.
Agree.
what I was
Obviously.
saying, yeah.
Yeah.
Yeah, I mean,
Right patients you may not.
we
He's
have
done excellent
learned.
job actually. He has done excellent job.
I'm sorry, I couldn't hear. I'm back again.
Yeah,
Excellent
great.
job.
We were just praising you.
We are
Andre.
just praising you.
You didn't miss much.
You see, Aniruddha, what I said was that if it other eye was okay, I wouldn't have touched this.
Yes, she was one-eyed. So, and the most difficult part for me was she came to me when I just joined as faculty, and this was my first year of my position here, so it was very difficult for me.
It immediately made you a mature surgeon.
Okay. Any other comments, or else if we do have a few minutes.
I think when we start peeling the membranes and at least one quadrant, we are basically onto that. So I may put a diathermy mark at 6 o'clock so that we know how much rotation and what is happening.
Yeah,
That's a great tip.
Good idea.
That's a great tip. And any thoughts on exchanging PFO with oil, or somebody would still go ahead and try PFO gas exchange and then put oil?
I always do
PFO oil.
I always do PFO oil.
Oil.
Okay,
I think
I
Alexander.
think it's an
bimanual-
individual perception. The way each one of us train, I think we take a call accordingly. Once retina is flattened down and laser is done, I think it's just the way we are trained. I think we take a call accordingly. I think either way is okay as long as you're confident with handling that step.
Yeah,
I think the
Alexandra, any
bimanual
thoughts?
by Constellation, the bimanual gives you very good control with direct PFO oil exchange. I think that's very useful.
Yeah, I wanted to hear something from Alexandra. Any thoughts, Alexandra?
I think it's a gorgeous case. I love the production too.
And he played really safe by thanking his wife too.
Yeah, exactly. It was very well done. I love the last slide as well. So, but I think it's a challenging case, and I just want to say, in a lot of these case presentations, it's giving a chance to a patient is important. Obviously you want to have a good pre-op counseling because sometimes patients expect things that we can't always deliver. But complex trauma cases like this, if you can try and give an option, and sometimes we're lucky and the retina cooperates. So beautifully done.
Thank you.
Nice.
I do have a couple of questions from the session from audience. So I'll just like try to answer as many as we can. We have only 7-8 minutes left. So the first question is for Dr. Murthy about his ILM peeling in high myopes. Do you want to share any specific comments while peeling the ILM in high myopes, and how do you deal with the instruments? Many a times they don't reach to the macula.
Yeah, so I just look at it preoperatively to decide whether I should do it without the PFCL, depending on whether there is this. If there's a dome-shaped macula, I feel I could reach the ILM. I would do it directly. I go from the disc to the periphery, so I would be able to peel the ILM. But in a lot of patients, we do have to do it under PFCL, wherein I stain it under the PFCL and then peel the ILM. Now, the only problem is the challenge is because of the length that we need. So I do use a 26 gauge 1.5 inch needle to first give me the flap, so that then I can peel it, because holding it is a problem because the retina is extremely thin. So you try to hold it, you'll produce a bleed, then you lose that. So each time you try doing it, you'll always have a lot of these problems. So I try to do that, or you could use a Finis loop. I use a 23 gauge wired one port, the active port, and I use 25 gauge instruments because then there is no leakage. It becomes very stable.
Yeah, and something more means which I particularly use it, that always start the ILM in a detached retina. It's safer to start from nasal to temporal. So you use the optic nerve as the lever and try to pull it from nasal to temporal. So that makes the job little simpler.